by equipping mental health professionals in Africa and the diaspora with the tools and agency to effectively care for those suffering from mental illness. We do so by fostering collaborations, creating accessible training and education programs for both providers and the public, and conducting and disseminating culturally relevant research and partnering with key stakeholders to advance mental health care on the continent of Africa. I hope you all visit our website and join us in membership. It's the agmhi.org. At the end and throughout this webinar, we'll probably reference a little bit too. We have an upcoming conference coming up in Nairobi, Kenya in November, and we hope you can join us there. There are 4 pillars as a part of the AGMHI, training and education being one of them, which I am the co-chair. My name is Michelle Durham. I'm a child and adolescent psychiatrist by training, and I'm located in Houston, Texas. I'm really happy that our panelists today decided to join me in this conversation. As a child psychiatrist, I feel like I'm going to learn just as much as each of you joining today about how do we really think about a rapidly aging Africa. I'm going to first introduce our speakers, and then we're just going to jump into some questions. I'm hoping to get us to about the half hour or so with questions that I have, but I'm hoping that each of you who are with us today use the function to ask questions yourself in the chat. Let us know what you're thinking, any comments you may have as we engage in this discussion so that we have robust discussion and Q&A for the latter half of our time together today. Isaac Adedeji is trained in medical sociology, anthropology, bioethics, and gerontology with a bias in aging and technology. His research addresses the health and well-being challenges of older adults in Africa and Canada. His primary focus is on bridging the technology and aging gap through culturally appropriate approaches to support cognitively impaired older adults in Africa. He is an adjunct lecturer in the Department of Sociology at Hallmark University in Nigeria, where he teaches and collaborates on developing a training program for geriatric nursing and innovation. He was an NIH, National Institute of Aging, and Fogarty International Fellow at the Harvard T. Chan School of Public Health. Everyone has lengthy bios, I should say, for all of us, everyone participating. For the purposes of time, I'm going to limit it a bit, but you can get more information. Just reach out to us if you'd like to know about each one of our panelists. Djibril Moussa is a general psychiatrist and a global health specialist. He is currently an Atlantic Fellow for Brain Health Equity at UCSF in San Francisco. It's a non-clinical fellowship that is mainly focused on dementia. He works in the intersection of public mental health policy and aging. His upcoming work will be integrating old age into primary care settings in Somaliland, which is a territory in northern Somalia. Before going to UCSF, he was an assistant professor in psychiatry at Ahmad University in Boroma, Somalia. And Dr. Sihle Nhlabathi is a geriatric psychiatrist with over 5 years of experience caring for older adults. She's dedicated to improving mental health in aging populations with expertise in diagnosis and treatment of late life depression, anxiety, dementia, and other age-related mental health conditions. She's passionate about providing compassionate and personalized care to her patients, supporting their unique needs, and promoting healthy aging, and really committed to advancing the field of geriatric psychiatry through education, research, advocacy, and caregivers, advocacy for patients and caregivers. And without further ado, I would love to start with you, actually, and really thinking about Dr. Nhlabathi, really thinking about your experience, what brought you to this world. And I'm going to ask each of you this particular question of just really helping the audience understand, how did you get here? What's your passion about? Why did you start thinking about old age? It's not something that, at least in psychiatry in the United States, there aren't many people going into this sort of aspect of the field these days. And so why is it important? And how did you get into the space of caring for the aging population?
I would like to start by kicking off with this.
Djibril, if you give me one moment, because I'm sorry, I wanted to start with Dr. Sihle, and I'll get to you, and then I'm going to go to Isaac and then Djibril, if that's okay.
Thank you for having me, and thank you to everyone that is attending the webinar. There's a lot of reasons, Michelle, that you get into psychiatry. I've heard a lot of them over the years, and I think you start to relate to several of them. but particularly for geriatric psychiatry, it was just eventually getting to a place where you were having training and it answers a lot of the questions about stuff that happened in your childhood. I was particularly very scared of my grandmother. She was quite unwell during the time where we started to, see and notice the world. And you'd have episodes where she would be quite uncooperative, aggressive. As time went on, she started to lose a lot of her cognitive ability, which then translated into a functional decline. And she needed a lot of assistance with activities of daily living, whether complex or basic ones. It wasn't a pleasant experience, but what was interesting about it is we didn't see it as abnormal. It was just part and parcel of what the family had to go through. It was interesting later on to find out that actually there's a lot that can be done to influence, good health in aging, to make sure that there is still quality of life. So yeah, that's what started the deep dive into geriatric psychiatry.
Thank you. I'm sure there's a lot more you can say, but we'll keep talking as we move along. And so, Isaac, if you don't mind, sort of similar question on just thinking about how did you get here and some of your interest in work so far.
Yeah, thank you very much, everyone, for coming into this webinar today. My journey into gerontology and then on to aging and technology started in 2012 when I wanted to start my PhD. And I really hope that my PhD supervisor back in Nigeria is here today. I had said I wanted to study how nutrition supplement works for people. And then we got talking, and then I ventured into aging. And the PhD led me to collect data from more than 1,000 older adults in Nigeria. And I observed the trajectory of neglect and the problems going on in that population. Very profound. So I went on to become a postdoctoral fellow at the University of Maryland, where I studied the ethics of doing research among older adults with cognitive impairment, and was more like narrowing things down. And then I got the opportunity for the Fogarty funding, the postdoctoral fellowship, at Harvard, and I was successful.
Hello.
And then yes, my mentor is here today as well. Professor Adeshola Oguni is the foremost neurologist in Nigeria. And so he had mentored me through this process. And then when I got the opportunity to come on a scholarship to Simon Fraser University, he was one of those people who encouraged me to come on this journey, and to also say, look, you need to focus on how to develop frugal technology to support older adults, living with, cognitive impairment. And ever since, the journey has been so beautiful.
And will you describe a little bit, Isaac, just about what you're doing now in the technology piece of your research?
Great.
Just so people have a little bit of an understanding.
Yeah, thank you very much. Yeah, so currently my research is in three folds. First, I'm doing an environmental scan of available facilities, healthcare facilities to support older adults in Nigeria. The second part of it is to develop a training manual to train caregivers of people living with this condition, mental health conditions, dementia, and all of these challenges. And the third part of it is to develop a technology, or to come up with an array of technology to support the people living with these mental health challenges and their caregivers. So like the three dimensions of the research are interwoven. We want to do an environmental scan. We want to develop a training model. Then we want to actually develop an array of technology to support older adults working and then caregivers in this part of the disease spectrum, as the case may be. So currently, those are the things I'm working on, and yeah, I've had opportunities to also present as guest lecturers in some of the universities in Nigeria to talk to community of older adults, you know, about some of those technologies. And the most recent one I had was in November last year, where the older adults came back to say, what we want is a technology for us and by us. And I've been trying to also explore co-creation opportunities, you know, with older adults back in Africa to be able to, you know, develop some of these ideas and then create technology that meets them at the point of their needs and then satisfies the problems and answers the questions.
Yeah, excellent. So I hope that gives the audience a little bit of hopefully questions they can direct to you too, as we get to that part about some of the technology. And I think it's super interesting how you're saying some of the older adults were telling you what they need. And so I'll probably come back to thinking about that too. And last but not least, Djibril, you're doing some interesting work these days, and you've kind of decided to really spearhead thinking about old age and thinking about it from a public policy perspective. So I'm just interested, how do you came to this work? How did you get here? Because you're also a child psychiatrist, if I'm remembering correctly. No? Oh, I made that up. Maybe I thought you were a child psychiatrist. But would love to hear just about your journey as well and your passion now for old aging.
Yes, my passion comes from a strong passion I had for psychiatry previously. And, you know, I come from a place that is almost not part of the international community, but in a post-conflict setting. And my interest in psychiatry started at med school for me. And the reason was where I came from, there were no psychiatrists. And we speak today, I'm the only qualified psychiatrist for Somaliland. And I come from that unique perspective where I actually lead psychiatry in my country. And where I came into the story of old age psychiatry or geriatric psychiatry, it's clear. Our population is aging, our young age are immigrating, and then we have a huge number of old people who are aging. And in Somaliland, what's happening, for example, and which is true in many African countries, is that the life expectancy is increasing, the quality of life is improving, and many people are living into old age. And the problem is, recently I reviewed all the psychiatric curriculums in the medical schools in Africa. The problem in Africa is with few countries like South Africa, even we don't have geriatric psychiatry training, formal training in the continent. And the other thing is, when it comes to public policy for Somaliland in 2012 to 2014, I was the secretary of the group that wrote the Somaliland mental health policy. Old age was not even on the document. But you see how it was neglected, which led to my internship at the WHO regional office in Cairo, Egypt, because my country belongs to the Middle East section of the WHO, not the Africa section. And the interesting side of the story is that old age was still a neglected field within global mental health landscape. It's also true in the African continent. And my interest brought me here to San Francisco to work on an old age related area. And my work is mainly on dementia. But my scope of work when I am in Somaliland also looks at clinical and public policy aspects and where I integrate. And the reason we do this is that people with mental health disorders are neglected. Clinicians may overlook them. And we have a lot of issues in Africa, as we have a double burden of infectious diseases. For example, people aging with HIV in Africa, for example, which is an interesting area. Because I did my psychiatry residency in Ethiopia, and I would take care of a rapidly aging HIV population. And then I will give you an example of a case why that's so relevant. A guy just walking in, he was 78 years old guy, and he had memory problems. Everybody thought that he had depression, for example. But this guy was actually dementing with HIV dementia. And everybody overlooked him. And then when I did physical exam, he had shingles and stuff like that. And you could see that clearly. And that in many African countries, even the psychiatrists overlook why all age mental health is important. For example, we don't have a lot of neuropsychologists in Africa, widely neglected, and geriatric psychiatrists are among the smallest group of especially psychiatrists in our continent. And that's why when I'm working, I spend like half of my time working as a clinician, as a general psychiatrist, but now I know for sure I'm going into geriatric psychiatry. And interestingly, as I come from Somaliland, my training for geriatric psychiatry will not be in the continent. I have to pursue it elsewhere because the number of positions that you can get as a geriatric psychiatrist is so limited in the whole continent. And you see, in terms of training, in terms of policy setting, in terms of clinical prioritization, all age mental health is just neglected in a continent that's rapidly aging.
Mhm.
This is
No,
quite interesting.
Yeah, very interesting, which is why I appreciate all of you joining us today. And I probably think everyone's a child psychiatrist because it feels like we've been focusing a lot on these webinars on child psychiatry. So I'm really glad to bring this to the attention of all of us, including me today. I do want to go back to thinking a little bit and to Dr. Sihle about just what you're seeing and like what are people saying? I know you have thought a lot about caregiving and how do we mobilize resources to the aging population. So a little bit of just the practical on the ground, what is happening in day-to-day interactions, but also if you know or have thoughts about too, how do we really mobilize resources to this aging population that need it so desperately?
Yeah, thank you for that, Michelle. So it is, the situation is as dire as Djibril is painting it out to be. I can just talk to the context of where I am in South Africa, which is regarded as one of the lower income countries that have a better infrastructure. One would think that you would have a lot more resources that are meant for the elderly, but it's not the case at all. We have high population numbers, 60 million South Africans, and you know, there's a high percentage of those that are living for a longer time. And as Djibril was saying, this is due to advances, you know, in medicine, good genetics for some, you know, and the changes in terms of economics and politics. And because of these advances, which are positive things, people are living longer, but this is a population that hasn't been planned for. It is estimated that the population of elderly will double from the levels that we have now, where we are sitting at about 9%. It will double by 2050. And already we struggle in our primary healthcare system to have general psychiatrists, not just general psychiatrists, but other multidisciplinary team members, your occupational therapists, your social workers, your neuropsychologists, all these team members that are needed in order to have, you know, a comprehensive care for an elderly person. There's a paucity in that. In South Africa, for example, I will have these numbers, of course, just purely because I'm a geriatric psychiatrist, but there's only about 6 of us in the country. And one then has to imagine what is going on in, you know, war-torn countries, what is going on in countries that are in economic difficulty, where infrastructure, it's not coming now, it's not coming in the future, and you just have to make do. Why are we making noise about this? We make noise about the elderly because there are changes that happen when somebody is aging. For example, there's a decline in volume loss in terms of your brain. There are changes in neurotransmitters. There's a decline there. There is a phenomenon called immunosenescence, where the immune system of an aging person does not quite respond like that of a younger person. There are changes in terms of inflammation that occur in older bodies. In terms of organ functioning, there is a reduction in cardiac output, for example, reduction in renal functioning. If you look at changes that occur, hormonally, there's a reduction in estrogen, reduction in testosterone. There's an increase also in the amount of medical conditions that one gets diagnosed with as time goes by and you age. I'll just pause there and ask, I see messages about the quality of the audio. I'm not sure if is it something I can do?
We can hear you fine. I think it's just they need to change their settings.
No problem.
Thank you.
Yes. So I was just talking about why we care so much and why it's important to have multidisciplinary teams working on this. With aging, there's also increasing frailty, loss of muscle mass. There's a higher risk for fractures, therefore a higher risk for morbidity. These are things that affect particularly the population that we are talking about, elderly. So when you're trying to treat an elderly person, it requires a higher input in terms of the multidisciplinary team members. There was research that was kind of similar. Probably mine was far more rudimentary than Isaac's research. I was doing it for my MPhil, but we were looking at experiences and concerns and receptivity in accessing digital health information and resources, particularly for caregivers of older adults that suffer from major neurocognitive disorders. And the themes that emerged there was that utilizing online resources was experienced as a costly exercise. So we have websites in South Africa like Dementia SA, where caregivers can go there and get information that is at least evidence-based. But the internet costs a whole lot more.
Sorry, just unmute, Sihle. That was an accident.
Yes. So I was saying that the caregivers that accessed digital or online tools perceived this to be an expensive exercise because they off data costs. And I think this is one of the challenges that we find across the continent, wherever you are. There also was a lack of awareness, actually, in terms of that there are actually some tools and there are places that you could go to online where you could access this information. Participants of my study also found that the frustration was that there were a lot of gaps in knowledge. So there are no interactive, what shall I call it, platforms where they could ask a healthcare provider or get real-time, feedback in terms of whatever questions that they would like addressed. The participants also did actually respond positively. So they were willing to give feedback. I know perhaps maybe you would want to make a digital tool of sorts, but I think it's also important to remember that a part of what happens with aging is that cognitive decline. So one of the things that you actually find is that elderly persons just kind of stop really prioritizing their phones. They don't really get onto the internet, and it's a function of just the amount of cognitive energy that needs to be utilized, to try and get around digital tools and, accessing websites, vision changes, for example. So there's a lot of work to be done. It's important that we look at, exploiting tools that we can get online. But I think that it's one of the only ways that we can get or access to a much bigger population if we utilize, online tools.
Excellent. And you give us a lot to digest. And not to don't minimize your research. I think it's very important research that you're doing, and really understanding the needs, right, of the aging population. You gave us a lot to sort of think about, from the medical comorbidities that are happening for folks as they get older, to also how do we mobilize resources so that they can use them and that they can be more accessible. With Wi-Fi connectivity issues, smartphones maybe not as accessible. So how do we do this work with them? I appreciate all the work and thought you have put into working with folks in old age. It gives me a nice segue, I think, to Isaac, and thinking about how you mentioned focus groups earlier, which maybe me and other folks in the audience want to hear a little bit more about. What are people saying? And to Sihle's point around, not everyone has connectivity, not everyone has a smartphone. Maybe they don't want to get on the web as they age. So how are you sort of thinking about all of those things, even though we know technology is here and a lot of people are moving to just putting everything online? So what do we do? So those are sort of three big questions, Isaac, but hopefully you can give us some thoughts around that.
Great. Thank you very much for that, Michelle. Those are three big questions, but I'm going to give a bit of an historical context so that we can understand how all of these things fit together. For example, Nigeria just recently passed into law a Mental Health Act in 2021. Before 2021, the only mental health law, of course, it wasn't called the mental health law, it was called the Lunacy Ordinance, was in 1958. Now, before 1958, we've had the ordinance with the British style in 1916. Now, I'm giving this historical context for us to understand that the mental health of older adult as a space of knowledge, as a space of research, as a space of intervention, remained neglected for a very long time. I'm saying this across Africa. Now, in 2002, there was what we call the Madrid Plan to come up with policies to support older adults. In 2002, most countries in Africa did not begin to implement some of those things as frameworks or policies within their countries until the early 2000s, like 18 years gap in between. In 2018, there was what we call the the dementia framework. In Africa, as I speak, not up to 5 countries have it. Now, it's a very neglected area. Now, back to how we can now address the current challenges. One of the reasons I opted to come to study aging and technology in Canada at Simon Fraser University was because I looked at the preliminary data, of course not preliminary data, my PhD data, and I observed the trajectory. And I figured that, look, the only way we can bridge the gap, the only way we can close up, we can cover ground with all of this space, those large spaces we have created in the policy space and in the research space, would be to begin to think about technology. So technology is the only opportunity for us to really compress time and be able to address these issues. Now, in my research, I found out that, of course, because of the prevalent poverty in the country, the lack of policy that supports and protects older adults, the challenges with the health system, the fact that geriatric nursing or geriatric mental health, or in fact, the field of geriatric medicine itself is not growing as it should be, right? It's important for us to begin to ask the older adults, even connect with the newer generation, to know what exactly we can do to bridge this gap with technology. So in one of the interviews, or one of the sessions I had with older adults, it was clear that yes, there's a problem of poverty. But even if there's going to be poverty and we need technology to support us, we need a technology that is homegrown for so many reasons: for data protection reasons, for confidentiality and privacy reasons, for usability reasons, for the functionality reasons, for how effective and how versatile the interface is going to be, right? Now, and the easiest way we can explore, the easiest route, as we speak in Africa, is to adopt our smartphones as the gateway to access technology, support, and care for older adults across the board. Now, the most recent research, of course, shows that the prevalence of dementia, for example, is growing 4.9% crude rate as we speak in Africa. And it's been projected that in Nigeria, as I speak, 15 million older adults live with dementia. Now, I was having a conversation with one of the doctors, one of the community health physicians, just last week. And then I was asking them to participate in the Alzheimer's Disease International Survey. And then we're having this conversation about how are we even sure that this is prevalent? I said, the fact that you only see probably one in a year, and across the total population of over 250 million Nigerians, tells you how profound this challenge is. And Nigeria is projected by 2030 to be the location, I mean, the country that has the largest population of older adults in Africa. So it's a big problem. Technology is the only way out. Now, I do know that we have a lot of issues around our tech support, in terms of the smartphone penetration, in terms of internet penetration, in terms of the cost of mobile internet, in terms of even the literacy to be able to use a phone, right? The challenge with power and energy, electricity, and of course, the challenge with new technology platforms like the 5G. Most people in Africa have not even mastered the use of the 4G, but we've migrated to 5G in 2022. Right, in Nigeria, for example, and because that is where the bulk of these issues will emerge from. We are focused. I am personally focused on Nigeria because I believe that all these things will connect to other parts of Africa. For example, I was at the United Nations last month, at the 14th open-ended working group of the United Nations for aging. I mean, to come up with recommendations to protect the rights of older adults. As I speak, up until the 20th of May 2024, globally, there was no kind of document that protects older adults. Up until 2024, globally, there was never a document that protects the right of older adults. Mm-hmm. So it's a neglected space. And that is why my own perspective to it, my own approach to it, is to come up with technology to support older adults and caregivers, especially those older adults who have challenges with mental health. Dementia is just one. You have older adults dealing with schizophrenia, dealing with all kinds of mental health issues, right? Dealing with bipolar affective disorders, dealing with all manner of diseases that affect their mental health. Depression, as we may say, it's common or it's normal. Depression arising from loneliness and social isolation. Yeah, and that's another emerging area in Africa as we speak. So in 2023, I published a scoping review that looked at, that considered the experiences of social isolation and loneliness during COVID, right? And we observed that significantly, the use of smartphones was very, very significant in addressing social isolation issues. And that was where some of those solutions we've been talking about came from. If COVID-19 separated older adults from family members because of the vulnerability, of the morbidity among the older adult population, then it's important to begin to look at what worked in that context. And we found out that the use of smartphones worked. They did not have a mastery of it. My scoping review I published with Andrew Wister and John Pickering from Simon Fraser University showed that the older adults do not have a mastery of the technology. Now, they are willing to learn the technology, and there is another population that is not willing to learn the technology because of the fear that comes with, new ideas, new innovation and all that. But one thing that we found out in another very recent research that we have just concluded, or review that we concluded, is that everyone is afraid of innovation, regardless of how confident they may look. The important thing is to also begin to think about investments in building the capacity, building the digital literacy of older adults. Now, the way we think about it is this: yes, it is possible for older adults in Africa to be behind in terms of formal education. Yes, in fact, that generation of people born before 1960, who are currently the aging population in Nigeria and Africa as we speak, did not have sufficient access to primary education. So it's a big gap. A lot of them did not use technology in their workplaces when they were in their full careers. A lot of them never had access to the kinds of technology that we have around today. So the way to bridge the gap, as we hand the technology to them, is to develop a system, a structure of training within the communities at the local level that speaks the language of the people and then makes technology culturally appropriate. Until we make it culturally appropriate, it will not be culturally acceptable. And it is through education, it is through health promotion activities to endear older adults to the use of smartphones, teach them how to use it, teach them how to stay protected, right? And ensure that they are able to connect with the world. And then from there, we can begin to take issues of mobile health up from there. Older adults will be able to use the mobile health apps on their phones, whether they are cognitively impaired or not. Like helpers or caregivers or informal caregivers will be able to support them to use technology to access healthcare, as the case may be. So that's some of the dimensions we've been looking at.
You gave us a lot there, Isaac, to digest. We could probably have 3 more webinars. I would love for folks in the who are listening. We got one question in our chat, but please put more questions. I want to reserve some time for your questions, so please add them. There are a couple of things that you said, Isaac, that maybe I'll have Djibril. I know you're going to maybe say some other things, Djibril, but one of the things that I thought was striking. There were many things that were striking, but one is thinking about. And I'm going to phrase it maybe not the same way you did, but thinking about globally the protection of older adults. I mean, and no policy, no language even on paper, even though, right, policy to practice always takes some time. To not even have that policy is pretty incredible. That's one. The second thing is thinking about essentially what we've coined in the US is this digital divide. So even in the US that does have 5G and everyone can get smartphones and all that stuff, there is still this divide between poor people and people who have money and the neighborhoods they live in, and the lack of connectivity, which I know the US is trying to make, and with this federal administration making strides, but thinking about this digital divide that making some progress in the US, but globally there's a huge between the haves and the people that don't have that technology and everything you need. And so when we think about this though, Djibril, these are a couple of my things that I feel like lead into some of this policy, and thinking more about how do we can get them the smartphone and then what, they can't use it and then what, right? What are your thoughts around that, Djibril, of thinking about this from a policy perspective and just a larger global population health perspective?
Absolutely. When it comes to public policy and public mental health policy, and it comes to old age, what comes into mind is where we put old age mental health in our public policy settings, not only as a mental health issue, but old age as a social issue. And then we are talking about public health issues in all policies. That comes into infrastructure, it comes to your road, it comes to your housing, it comes to your food. And as you know, so many older people in Africa are food insecure. Before I go to technology, it's like surviving, how they can pay their medication, how they can pay for their housing, how they can pay for their electricity. If they break their hip, who's going to cover their surgery, things like that. Where they go, do live, where is the environment and the neighborhood they live, how secure they are. And interestingly, because now at the Consortium of Universities in Global Health, myself and colleagues set up an interesting group on old age and public health, which not only includes mental illness, but also other physical health issues, because they go together. For example, if someone is old and they are blind, who's going to protect their human rights? If they're abused, what are the legal infrastructures to protect them? And when we talk about the internet penetration in Africa, we're talking about the elite 10% rich Africans who live in major cities, who have access to internet and mobile phone. And everybody else who lives in a rural setting. For example, I come from Somaliland, where it's the only African country before I came to the US that had 5G plus network. It's unusual context. Although nobody recognizes it, but they had excellent technological innovation. But that's the reality. But the condition is how we protect when we use technology, which is, I will talk to you, Isaac, when we meet with Philadelphia next month. And the interesting thing is, when it comes to old age, do we regard in Africa as a public health issue? That's the key issue. Is it on the public health agenda? In last year in Nairobi, we had this interesting Nairobi Declaration on old age and dementia, which is a strong movement, still pushing. For example, we give you Ethiopia and Kenya now, for example, are working on their dementia action plan, which is excellent. And other African countries should follow suit, which is an example. And South Africa is doing fantastically well. I was in Cape Town last month. And the other issue is, when you look from a public policy perspective, is how we support the whole infrastructure, how we integrate it into other healthcare systems. We are talking about finance, we are talking about social security, we are talking about health, education, housing, and income, and things like that. And then looking at the overall picture is critical for me when I look at my public health lens. We don't only look at mental health as general, and for example, give you an example. Many older Africans have an issue with addiction, and nobody discusses about addiction psychiatry for this population. Nobody. If they walk into a clinic, they may be assessed for depression or for dementia. That's it. But I know from a clinical perspective, they suffer from everything in the textbook in terms of psychiatry, and plus all comorbidities, medical comorbidities. And that's why, for example, in Africa, we give you a commitment we made in our continent in 2001, like the Abuja Declaration for Health Financing. We said we put 50% of our GDP in health. No country puts 50%. They put 3%, 4%, 3%, and things like that. And then what you see when you do that kind of budgeting for health, what will go to old age? That's the question. And you have a continent that's aging. Now the dynamics of our public health dynamics is changing. Previously it was like maternal health, child health, bit of common mental health disorders, as they call depression, anxiety, substance use. But now that we are totally aging, you have a huge communicable disease burden, strokes, hypertension, diabetes, you name them, and emerging cancer also. We have a lot of things that's happening in the continent, and resources are competing. The problem in Africa is our resources are so small. And old age, when you go to your Minister of Health or your Minister of Finance, I guarantee you they will laugh at you. And they will say, I don't have money for it. And that's the way we have to look the dynamics and the bigger picture of how we advocate and raise awareness and how we win resources for all the people on all mental health, in particular within our neglected mental health policy. And our old mental health policies in Africa are either outdated, they're from former colonial, as Isaac said. And I upload Nigeria that they updated their public health policy and they go into the mental health law. Amazing story in Nigeria. But in many countries, it's not happening. That's what I know. When you see at the Africa level perspective. And every country has its own unique challenge. Thank you, Michelle. I will leave the time for questions.
Great. And we do have a few, and which is great timing. We have someone is not on mute, but we'll keep moving. I'll go to Sihle. There was a question that came up in the chat. And so I'll just read that out loud. How feasible is the implementation of the technology digital tools for older patients with dementia in remote areas of Africa? For instance, the consideration of low-cost technological interventions, particularly because of the rural and low-income areas in Africa. Another instance is the usability for older patients and integration of African cultural contexts, like the translation of health apps into local languages, such as Swahili or Yoruba. Very good question. So, Sihle? It was directed to you, but I'm sure other folks can answer too. Go ahead.
Yes, it's quite a broad question. I think the first answer is it's not an impossible task, but it's a task that needs a huge call to arms across the continent, you know, across the world. It can only work with collaboration, and not just from a clinical standpoint, not just from the community standpoint, but also from a public health and policy perspective. For example, if we were going to succeed to get zero-rated calls or zero-rated data, you know, to access some websites, that's both locally it will translate, but it's something that will need to involve governments, it will need to involve health policy. So it is feasible. I think it's very important also to see what is there. I think there are actually, it's not like there's nothing altogether. For example, in South Africa, certain of the websites that we have could be improved. So you don't need to make something totally new. It would just be to have a look and see around you and collaborate with other clinicians and, as I said, public health specialists to see how some of what we already have can be made better and made accessible across. It would be important also to just maybe conduct implementation studies, you know, to see if a certain tool is implemented, you know, what learnings can we get from that? I think we speak a lot about technology, but just even on a day-to-day basis, you know, things like promoting healthy aging. I think that message has been lost, you know, in our community. It's kind of just time goes on and yeah, you age, you get a few lines, and but just educational programs to teach populations how to age healthily, or what is healthy aging, exercising, monitoring your health status way before you hit your 60s, lifestyle change. Culture also did come up as one of the targets, you know, or as one of the barriers that are often limiting. For example, in our populations, there's different thoughts about the utilization of retirement facilities or keeping your elderly at home. So culturally appropriate interventions that would be accepted by the communities. For example, perhaps daycare centers as opposed to sending our elderly to retirement facilities. In some communities, it's taboo. So,
so we'll just move. Sihle, we can't hear you at this point, but that's okay. I might just.
Okay.
You cut off a little bit. Oh, there, you're back.
Sorry, probably a network issue. I was just saying, finally, that it's important, as Dr. Djibril was saying, to address social determinants, because if you put it on a hierarchy of needs, yes, we need to address older adult mental health, but we definitely need to address poverty, unemployment, housing issues, social isolation, immigration problems, and
Okay, so I'm going to move on for the sake of time as well. We have about 5 minutes, and there's a couple more questions. And so, Isaac, I'm gonna go to you. Sihle brought up a couple things that I do want to just point out. Like, we often forget about sort of prevention and promotion in all aspects of life. And so for old age, how do we age gracefully? And there's probably this culture globally of silence, right? Of like, nobody wants to get old. We know plastic surgery, all the things are happening all over. And so nobody wants to age, but how do we age gracefully? And that is okay, but and support people even in old age. We think about younger and middle age of like, they need all the social supports, right? They need food, they need housing, they need water, but old age is just as important. And so not forgetting those basic needs for everybody globally. And so I appreciated you pointing that out, and also thinking about just educating folks on how do you just live a healthy life in general. Isaac, one person was, how do you intend to get Nigerians along with some of these new ideas, especially older people in the rural areas, which is, I think, a great question.
Yeah, great. Yeah, thank you so very much. To take it up from the need for health promotion. It's a very important aspect of this conversation, and I would say that in the dementia study space, I do know that the identification and intervention for dementias in elderly African study had developed a cognitive screening in the local to take account of the local context, to be able to guide the screening for dementia, because for a very long time we have had to rely on the MMSE and the MOCA scale to determine and to diagnose dementia. Now the IDEA study is doing something in that regard. I also know that the Alzheimer's Disease Association of Nigeria, in 2021 set up a community-based screening facility where older adults are encouraged to come screen for early detection of dementia. And of course, I do know that the Ibadan Study Group as well at the University College of Nigeria, it has also come up with public awareness in programs and all of that. The Alzheimer's Disease Association of Nigeria too is leading this campaign, going on radio stations, speaking to people, having interviews and all of that. And I do know that a couple of brain health organizations in Nigeria are also pushing this frontier of health promotion, of prevention, of brain health, of avoiding all of those conditions that predispose people to challenging mental health issues. So on that side, I do know that researchers in Nigeria are working so hard to ensure that we make the information and health promotion activities as close to the people as possible. I also know that the Alzheimer's Disease Foundation of Nigeria, I had the privilege of speaking for them, as a guest speaker in one of the webinars with community caregivers. So they have a group of community caregivers, they have a group of community members where they interact, talk about brain health, talk about health promotion issues, the need for good sleep, the need for good food, the need for exercise, the need to avoid sedentary lifestyle, and a whole lot of other things like that. So on that side, I know for sure that something is happening, but not so much. Now, on the side of making technology available to Nigerians, making technology available to Africans, like I said earlier, the metrics may look like they're against us in terms of the infrastructure to support technology. But the truth of the matter is that that is our way to connect, to bridge the gap. And it's one of the reasons I've also been talking about what we call frugal technology. Frugal technology is technology that is developed with that requires less resources. You know, frugal technology that goes into the programming, that goes into the development of technology, such that even the amount of data required to power these devices would be minimal, right? Such that you don't need regular power supply. For example, in Nigeria, yes, we have challenges with electricity and power supply. You don't need to have 24/7 electricity. You can use solar energy. These are things we are thinking about in the grand scheme of things. And I can say, just like Michelle, you said earlier, that to translate these things, right, will take a number of years, but it's important to start the conversation. It's important to begin to do the research. It's important to begin to have those discussions with people until we finally find the opportunity to push things in the direction we want it to go.
Love that. That might be close to the way we should end. I will ask Djibril, you have in 1 minute, Djibril, just, you know, there's been a couple questions that are related to the same thing. And is there anything if you think about it policy wise, what is our call to action maybe?
The call to action is simple when it comes to policy. It's all about advocacy and putting all age on the table. Unless we don't talk to the politicians. And I will tell you a trick. When you are working with public policy, you have to put everybody on board, all your stakeholders. That mainly includes your politicians, people who make decisions for the budgets. And I will give you an example. For example, in Somaliland, we had to tax, for example, cat, for example. And for me to win that and get like $10 million tax on cat, I worked directly with the Minister of Finance and the President. And policymakers are key. You sit down with them, you sell your policy, and then what we do is that you will win, because as a professional like public health or psychiatrist, you will not do anything. You go to the table, we talk to the policy decision makers. That's where that's where the goal is. Go to your policymakers, advocate, speak for the cause, and move forward.
That's right. I just want to say I appreciate each of you today. I think this was a phenomenal discussion, probably the start of many more to come. And our own call to action, I think, as AGMHI, to continue thinking about old age, people aging gracefully, and how do we support this effort globally, I think, including here in the US as well. And so you know, Isaac and I was going to say, Isaac, you just said something at the end of your just a few minutes ago about if we don't do the research, if we don't start having these conversations, right? If we don't get out there and ask people who are aging, what are their needs, nothing will move. And so it's a call for all of us to sort of move to do the work. Thank you so much for participating today. And thank you everybody for joining us. This was a fantastic webinar. We did put a link in the chat for you to fill out a short evaluation. It's really short, but it really helps each of us understand what do we need to do next for our webinars? How do we improve our webinars? What are some topics you'd like to hear about in the coming months as we continue to plan some of these through the AGMHI? You can always view it and look at it after at our website, agmhi.org. So for those on the call who know maybe people couldn't join us today, there is a link later on that will be there for others to be able to view these webinars. Thank you, each of you speakers, for all the work you're doing in this area and really moving us all forward and making us think more broadly about what we need to do moving forward. With that, I hope everyone has a great rest of their day.